Before I introduce the next speaker, I just wanted to mention that we have a unusual and very nice occurrence this year in that two of the faculty members at the University of Louisville, Dr. David Casey, who's chair, and myself, director of the Depression Center, have children that are here to present at this conference. And to me, that's a very remarkable thing to have happen. Brian Casey, who just recently graduated from the residency training program at the University of North Carolina and has joined our faculty, will be doing a workshop this afternoon on acceptance and commitment therapy. We don't ordinarily introduce our other speakers from the UofL that do our workshops, so I did want to mention that Brian is Dr. David Casey's son, and we're just delighted to have him here with us. Our next speaker is my daughter, which I am very pleased to have happen today, to have her with us. Laura is the associate professor at the University of Vermont School of Medicine, and she's program director of the family medicine residency at the University of Vermont. Laura graduated from Jefferson Medical College in Philadelphia and did her family medicine residency there. She then went to the University of Pennsylvania, where she did a fellowship in research and faculty development and received a master's degree. She graduated from the National Institute of Program Director Development and is actively involved in clinical practice, in primary care, and in working in education and research. Laura has collaborated with our group at the University of Louisville in doing work on meta-analyses of computer-assisted therapy, and Laura also co-authored a self-help book with me called Breaking Free from Depression. She's an expert in family medicine and in collaborative care, and today she's going to talk with us about the interface between psychiatry, mental health, and medicine. Laura?
Wonderful. Can everyone hear me? Okay, excellent. I am kind of a walker and talker, so I'm going to start out here as long as I don't have the feedback. All right. Thank you so much for having me. I'm Laura McCray. Again, I'm from the University of Vermont. I'm a family doctor, but also a researcher in mental illness in primary care and also in burnout prevention in medical trainees and folks that work in medicine. So I'm excited to be here in my hometown of Louisville, and I actually say it correctly up in Vermont, so people know that I'm really from Kentucky. And we're going to be talking about, well, we were just talking about precise medicine. We're going to go kind of way back over here to the less precise treatment of depression in primary care. So without further ado, and I'm not sure this clicker is working. Let's see. For the AV people, the clicker is not working, so I'll go back to the computer here. Whoop. Okay. Maybe if there's an AV person that could come help with the clicker. Thank you. Great. Awesome. Thank you. I don't know what happened. Oh, I just have to turn it on. See? You know. Right. Okay. So, oh. It's still not working. Sorry. Let's see. It looks like it's on. We're still having trouble. Would this work here? That'll work. Okay. Unfortunately, that's not working. Okay, great. All right, sorry about that. So we're going to review the epidemiology, the screening and identification of depression in primary care settings. Then we're going to take a really deep dive into the interplay between depression and chronic medical illness. Some really interesting data there. We're also going to talk a little bit about common medication pitfalls to kind of dovetail on Dr. Fry's talk. And then finally, we're going to also discuss the integrative behavioral health model and talk about collaborative care models in primary care, which might be of great interest to you here in the Louisville area. So as you all know, depression is incredibly common in the US. 13 to 16% of folks will have a lifetime prevalence of depression and a point prevalence of 8 to 10%. Those at higher risk are the elderly, women, those who are minorities, history of mental illness, a family history of depression, and then finally what we're going to really talk about today is having a comorbid medical illness absolutely increases your risk of depression. Depression has an incredibly high impact in the US. It's a major source of disability, as Dr. Clark discussed yesterday in his talk. There's an increased mortality with those who have depression, and that rises multifold if you have chronic disease as well. Finally, it's incredibly costly. And we're talking not in the millions, but in the billions, actually over 210 billion is the cost of depression in the US. Massive amounts of money. So how are we doing in primary care? Well, we're at the front lines of treating mental illness. Unfortunately, in Vermont, we have a 6 to 12-month wait list to get in to see a psychiatrist. And actually, right now, they're not even taking new referrals. So really, we're at having to treat not only depression and anxiety, but also severe mental illness in the primary care setting. And I'm seeing some family doctors nodding their heads. I'm glad to have some primary care folks in the audience as well. So unfortunately, in primary care, we're not that great at making an accurate diagnosis of depression either. So as you can see, of those with depression, only 47% are accurately diagnosed by their primary care physician. So in some ways where we might be underdiagnosing depression or not identifying it in some of those key populations, or we might be overdiagnosing as well. Now, when we take that a step further, we see, oh, I think it's now, excuse me, it's going on its own, which is fascinating. Okay, so just let me know if it keeps jumping. All right, so does it, oh, is that you back there? You're doing that. Oh my gosh. Okay. See, we're gonna have some fun, actually. So, ready. So we talked a lot about antidepressants in the last talk. Almost 75% of antidepressant prescriptions are prescribed in the primary care setting. This is huge. Think about the impact, especially in the context of Dr. Fry's lecture, about who is really doing the prescribing, and are we doing it accurately and in the right manner? Actually, we probably aren't doing that great of a job. The rates of guideline consistent care in primary care are actually quite low. And I think what's happening is that we're often treating minor or moderate depression when we know the data really suggests that we should be treating with antidepressant therapy at the moderately severe to severe depression level. But what we do, unfortunately, in primary care is we don't really make that accurate diagnosis of how severe the depression is. We'll talk about that in a moment. But first, I want to talk a bit and get us all interactive to talk a little bit about what are the barriers to treating depression in primary care and getting the treatment that folks need, including access to you all, access to psychotherapy and counseling. So I'm going to start with the first interactive learning exercise for my talk. And this is in the vein of University of Vermont, which the medical school is actually going to 100% active learning by 2020. No more lectures. It's hard to believe. So I'm still a little bit of a dinosaur, so I can't give up my lecture yet, but we're going to get talking a little bit. So I want you guys to think about what are the barriers that you see in your own clinical practice to getting the right treatment for the right patient, to accessing care. Think about that in your mind and turn to your neighbor and talk a little bit about what you see as far as barriers to treatment in your patients. Get talking. Excellent. So I'm going to have you wrap up your conversations. This is awesome. I love all the talking. But in the interest of time, excellent. Wonderful. So now, does anyone want to shout out a barrier that you identified in your groups? Shout it out. What barriers do you see? Time. Money. Stigma. Others. Resources. Awesome. Any other? What's that? Screening. Excellent. So we got time, money, resources, screening. You're exactly right. The literature bears this out tenfold in primary care. Stigma, the cost. I actually have a rural practice up in Milton, Vermont, which is 20 minutes north of Burlington. There's one bus in and out of town to the main city of Burlington a day. So that's it. And people who don't have the money to actually get the bus. So if I send somebody to a psychiatrist or a psychologist in the big city, in Burlington, they can't get there. So finances are a huge one in rural Vermont. So stigma, cost, transportation, access, right? I just talked about, we have a 6 to 12 month wait list to get in to see a psychiatrist in Vermont. So we also see lack of system support, and certainly those are at a disadvantage or undocumented or don't have access to traditional lines of care. Those folks are at the biggest risk here in the United States. So let's talk a little bit about the screening that somebody brought up. Screening in primary care, I wanted you to have a context of what we're doing right now in the primary care setting. The USPSTF is called the U.S. Preventative Task Force. It's kind of our big governing body that tells us what to do, what to screen for, whether to screen for prostate cancer or colon cancer or for depression and suicidality. So actually, the USPSTF does recommend routine screening for depression in primary care settings. This gets a grade B recommendation, which has very strong evidence behind it. So primary care physicians should be screening for depression. Now the caveat, as you see with that little star, is that the USPSTF says that we need to also have systems in place to have accurate diagnosis, to have effective treatment, and follow-up. So not all of us have that in our primary care setting. So we have to be cognizant of being able to have the support and the network there to help our patients access care. Now, I want to point out they also added in the most recent iteration, really important to highlight the pregnant and postpartum patients, and we'll dive into that a little bit in our discussion about the interplay with medicine. So next, very briefly, I want to highlight the really huge impact of suicide and the increasing suicide rate in the U.S. Currently, our U.S. Preventative Task Force does not routinely recommend that primary care physicians routinely screen for suicidality. That gets a rating of I, or insufficient evidence to do that. A caveat is that suicide rates are rising across the U.S. So in Vermont, we have the highest rate of increase in suicide rates, and Kentucky is not doing great either. There's a 36% increase, a rise in suicide rates, and this is CDC data between 1999 and 2016. And what's scary is that the majority, or actually a little over 50% of suicides occur in people who have no known history of mental illness. And as we know, it's more prevalent in men and kind of middle age. And so I think that might change as far as the screening in primary care. I think more to come with the U.S. Preventative Task Force. At the University of Vermont, we're actually piloting a suicide screening program in our urgent care centers. So more to come on that. It's just starting. So in primary care, we talked about that the USPSTF does recommend routine screening. What do we use? So you all use lots of different tools in your clinical practice, but in primary care, we tend to lean towards things like the PHQ-9 or the PHQ-2. And luckily, some of us in academic centers have EHRs that incorporate this or embed this within our EHR for ease of use. So we're able to pull it up right there at the point of care and click with our patient to see where they line up in the PHQ-9 or PHQ-2. So you all certainly know this, but for primary care physicians, we don't all really know about guideline-based care for depression. And so I think this is where we see, if I get the pointer going, I think that's it. Do I have that? Whoop, there we go. Okay. I'm not sure that's working really well, but I think what's happening with that misdiagnosis of depression is that often we get folks who screen in the mild to moderate depression, and those folks sometimes end up on antidepressants, whereas the data really suggests using them again in the moderately severe to severe category. And again, I know I'm preaching to the choir here, but in the primary care setting, we don't often take this to the next step and actually make an accurate diagnosis of depression. So we often rely on things like the PHQ-9 for diagnosis, or just a gestalt or a subjective impression that somebody has depression, but we don't actually go into the classic DSM criteria and really ensure that the diagnosis is accurate. Now let's get into the meat of the talk, which is really looking at medical disease and depression, to give you all some interesting clinical pearls for your practice. So I wanted to highlight some of the common medical disorders that sometimes masquerade as depression, that you might want to have an eye on in your clients. And you might want to actually advocate that they talk to their PCP about some of these things if you might have an inkling that something might be going on for them. So common medical conditions that masquerade as depression. Certainly, we all hear about hypothyroidism or underactive thyroid. So a simple test like a TSH might be a useful test to rule that out. Anemia, sleep apnea can cause profound fatigue during the daytime. And with our obesity epidemic, this is really becoming common in primary care. We see it all the time. So thinking about sleep apnea, are they sleeping well at night? Are they snoring? Are they really fatigued during the day? And is that impacting their depression symptoms? Vitamin D deficiency. For Dr. Fry and myself, who live in northern climates, man, our winters are long and cold and very dark. And so vitamin D deficiency is something that always comes to my mind when I'm kind of screening for organic causes of depression. And certainly you see some of those other things that are quite important to think about. Now, medications. We talked a lot about medication in the past lecture. When we look at primary care medicines, there are lots of them that cause depression symptoms, right? So if you have a client, be inclined to kind of think about, do they have a medicine list that's this long? Are they an older patient? Are they on a beta blocker? Or a narcotic, which there's certainly an interplay between chronic pain and depression. And we have to consider whether the narcotic is adding to those depression symptoms. And then you get also into some of these other medications, like anticonvulsants that some of our folks are on, prednisone for COPD, et cetera, and then Chantix or varenicline that folks are on for smoking cessation. So all of these medications can cause depression symptoms. So for us as PCPs, it's really important to do a thorough medication review before we start prescribing antidepressants. We might want to peel off some of their medicines to see if that helps first. Okay, great. Oh. Okay. And again, I'm preaching to the choir, but in primary care, we also need to be very thoughtful to be screening for bipolar depression and asking key questions about mania and also asking about psychosis, because we often miss bipolar depression in primary care, and we often miss psychotic features. We're lucky at UVM to have embedded decision support tools in our EHR, which also includes screening for substance abuse and alcohol use disorders. Also very important to make sure we look at that in the context of treating depression in primary care. All right, so now we're going to take that deeper dive into depression and chronic disease. So when you have depression and you add a chronic disease like like diabetes, like coronary artery disease, et cetera, then you actually have an increased mortality and increased cost of your chronic disease. And that's controlling for the severity of your medical illness. So why? This is our second interactive exercise. Let's think about, brainstorm, why you think chronic disease plus depression can really increase the risk of mortality and increase the risk of worsening chronic disease. And then share with your, oh yeah, go ahead. Adherence, excellent. Other ideas? What's that? Compliance, adherence to medications, compliance. What else? Hope? Lifestyle, okay. Say more about that.
They sit, they don't eat well, they feel quality.
Mm-hmm. Okay, so I'm hearing perhaps sedentary lifestyle, adherence to medications, et cetera, when you have depression plus a chronic medical illness. Well, you're right, but there's also something more, right, as Dr. Fry alluded to. There might be some deeper factors, some perhaps genetic factors, and there's some data that's really emerging about physiology. So there may be some pro-inflammatory factors that are happening with depression. There might be enhanced platelet aggregation, and there's emerging data about decreased heart rate variability. And I'm no expert in the physiology, but I think it's really interesting to note when we see some of the data that's coming out about heart disease and depression, it's fascinating. So we're gonna get there in 1 minute here. So certainly behavior. You might see more smoking, you might see more sedentary lifestyle, which certainly are gonna impact coronary disease, heart disease, right? Or other chronic diseases. Okay, so I am going to illustrate some of the chronic illness overlays with some cases. And these are actual cases from my own practice. Some of the details have been altered for patient confidentiality. So the first case is JP. JP is a 48-year-old female. She's a home care nurse with a past medical history significant for depression, hyperlipidemia, which is high cholesterol, and a family history of early heart disease. So she actually presented to our ER with crushing substernal chest pain. This, horrible chest pain. She ended up having an ST elevation MI, which is basically what they call the widowmaker. In her instance, she's already a single mom, and that would be incredibly impactful, right? This is the one that you don't want to miss. You see the actual EKG with the ST elevations. She went straight to the cardiac catheterization lab. Luckily, they got her there in time to stent open her coronary artery, and she survived and actually did really well. So she stayed in the hospital for 1 night, and she was discharged on a whole new slew of medications. This is someone who came in the door with no medications on board. So an aspirin, a statin, which is a cholesterol-lowering medication, and a beta blocker, and a new platelet medication that I don't usually use in my own practice. And again, in family medicine, we think about what's the psychosocial context for this patient. Well, she's a single mom, she has 1 income, and she has 2 children still at home. So this is a big deal to have a massive heart attack like this, right? Okay. So let's talk about depression and coronary heart disease. Really fascinating literature here. So depression alone, having depression, is an independent risk factor for developing coronary artery disease. We know this from several studies, and the first one is an extremely large women's health study. So anybody familiar with this big study? A couple people? So over 93,000 women were studied. This is the big study that changed our practice with hormone replacement therapy. For those of you who might remember, we used to give patches to everyone, right, for hormone replacement, but now we don't do that anymore because this study showed us that actually hormones might increase the risk of cardiovascular disease. So this was a landmark study for primary care. What it also found is that depression is an independent risk factor for developing heart disease. That is pretty wild stuff. And it's been replicated in several more recent studies, like the InterHeart study and the Heart and Soul study. Don't these have great names, right? So as you can see, the data really supports this notion that there's something more going on. Is it this physiology, this inflammatory state that might be predictive or for the development of coronary heart disease, okay? Now, let's talk about the flip side, like my patient, JP. She had a heart attack, right? So what happens to those people who have a heart attack or who develop coronary heart disease? Those folks, even if they weren't depressed before, are at much higher risk for depression, much higher risk. So 20% of patients with a heart attack will become depressed. These folks, unfortunately, have a much higher increased risk of mortality, of dying. They also, and if you look at the data, look at that. For women, they have 3 times the odds of dying compared to controls that have a heart attack as well. And for men, it's 3.05 odds ratio. So what are these mechanisms? Is it inflammation? Is it poor adherence to medications? Regardless, these folks are extremely high risk. people who have a heart attack and develop depression are 3 times at risk for suicide. It's very impactful. So, the American Heart Association does recommend very strongly for screening for depression post-heart attack. So important to note in your patients, if they develop a medical illness, to be really on the alert for relapse or resurgence of depression symptoms. Luckily, about 50% of folks will remit with their depression post-heart attack, but not everybody does. And again, these folks are at higher risk of dying. So treatment is strongly recommended. And I want to highlight this Kim study from 2018. This was just published in JAMA. So Kim et al. Looked at the use of escitalopram or Lexapro in post-MI or post-heart attack patients. They followed these patients over 8 years and found that these folks had a decreased risk of cardiovascular events, independent of other factors, so just perhaps the SSRI treatment. I think that's really huge. This made a lot of buzz in the primary care community, by the way. So we were all talking about it. It came out on Medline just a few weeks ago. And so this is really important to think about. If you're a prescriber in the audience and you have somebody who has coronary heart disease or had a heart attack, be thinking about directed therapies, kind of similar to what Dr. Fry was talking about, more precise medicine perhaps. There's also a lot of safety data on using sertraline in this population as well. Things to avoid. You heard about that QT prolongation, right, from Dr. Fry. So how many folks in the audience are prescribers of medication? Okay, so quite a few of you, right? So we really do want to avoid. There's a black box warning, regardless of whether we know the genetics of the patient or not, that citalopram may cause QT prolongation as you increase the dose. So in general, I would avoid citalopram in patients who have heart disease or heart attack. The other medications to consider avoiding are TCAs and MAOIs, as you can see, because they may have impacts on the heart and hypertension as well. So, goodness, you didn't think you would hear about CYP 450 twice today, would you? Did you? But it's actually important in primary care too. And we're at least in Vermont, we're way behind the ability to have the genetic typing at this point, but we are really cognizant of these different variations in how medications might play out in our patients. So as Dr. Fry discussed, there are some potent inhibitors of the CYP 450, and look at this. This is the reason why, for heart patients, that this is really important. The CYP 450 also causes alterations in anticoagulant levels, antiplatelets, beta blockers, and statins. Basically, all the medicines we put you on if you have a heart attack. That's crazy. So you have to be really careful about using some of these really important depression medicines in the context of heart disease. So remember, I think key clinical pearl for all the prescribers in the room, if your patient has a cardiac event, please consider to switch up their medications and think about escitalopram or sertraline. Key clinical pearl there. Great. Okay, now I'm a family doc, right? And so I want to mention some really important things about lifestyle modification. Someone mentioned sedentary lifestyle. That just as important as antidepressants or pharmacotherapy are our behavioral recommendations and interventions. Granted, they don't always stick, but we can absolutely give it our best shot to recommend these things. And the data supports using things like exercise and diet. So first, let's talk about exercise. How many folks suggest exercise to their clients or patients? I would say almost everyone, right? This is great. So several randomized controlled trials have shown benefits for depression. And the good news is that both low impact and high impact exercise have an effect. So you don't have to be a marathon runner. You can do something like Pilates or yoga or chair yoga. So when I talk to my patients who say, I can't do it, my knees, or I have arthritis, we just talk about just the brass tacks, the basics. What can they do just to get a little bit of movement going? So any exercise is good exercise for depression. And actually, those who regularly exercise, that might be protective for depression. So important to note in the context of chronic disease that we're talking about today is that it is useful, it's safe, and it also reduces depression symptoms in those who have both depression and chronic disease. Diet. So how many here also talk about diet, or maybe the Mediterranean diet? All right, I'm preaching to the choir, right? So, but there's great evidence, too, for using the Mediterranean diet for depression. I think this is Giovanna Fava and colleagues showed this, that it lowers the risk for depression by 50%. That was over 9,000 subjects in Spain. So the clinical pearl here is that the Mediterranean diet is good for depression, but in primary care, we also know it's really good for the heart. It reduces cardiovascular illness, too. So it's a no-brainer. So if I have a patient with a heart attack, I should be screening for depression, I should be treating depression, and I should also be recommending exercise and a healthy Mediterranean diet. Okay, let's return to JP. Again, she was my patient, had the crushing substernal chest pain, had a heart attack, and she survived and was doing okay. She came back to see me in the office after her heart attack, and she actually self-identified as depressed. She had previously had depression, but had been off her antidepressant for some time. So what I did at that point was I recognized that she was really suffering, but we had to mix things up a little bit. She had been on citalopram in the past. And right, should I continue that? Oh, okay, good. You're getting this. Great. So I stopped her citalopram, and then I switched her over to actually sertraline at the time. Now that we just had that Kim article out, I might be thinking about escitalopram more often, although I think it's still, is it non-generic still? For those, I think it's still non-generic, or is it generic? So, generic now. Okay, yay. Okay, it's generic now. All right. And for her, we talked about what are the barriers to care. I referred her for traditional psychotherapy, but she couldn't afford it. She had a massive copay with her insurance. So luckily, in Vermont, we have state funding to help provide community health team support in our primary care offices. So I was able to refer her to our in-house, basically embedded in the primary care setting, social worker for some brief interventions in the primary care setting. And she also, interestingly, her insurance paid for cardiac rehab, but it didn't pay for counseling. Isn't that crazy? So she got into cardiac rehab and got on the treadmill. And I remember Dr. Clark remarking, or someone remarking about this last night, is that why don't we think about, in the US, if you're going for cardiac rehab, you should probably have your counselor or psychologist right there, right? If the prevalence is so high and the impact is so high in these patients. So I've been meaning to reach out to the director of the cardiac rehab at UVM to see if we could get something cooking there. Okay. So case 2 is another patient of mine, CM, who is a 73-year-old African-American male with a history of hypertension, high cholesterol, and peripheral vascular disease. Unfortunately, this gentleman came in with a left facial droop and complete right-sided weakness to the emergency room. He presented way past where we give the medications that are clot busters to basically help prevent stroke from taking hold. So unfortunately, it had already really sunk in. So he was admitted to the hospital, had several days in the hospital for physical therapy and occupational therapy to help get him going again. He ended up going to a subacute rehab facility for additional rehab, and unfortunately, his right-sided paralysis continued. So let's talk about depression and stroke. So 25 to 29% of those patients who have a stroke will develop depression. One can only imagine what it must feel like to have a stroke. Unfortunately, these folks are at really high risk of mortality or dying, that those who have depression and stroke together are at 3 times the risk, or almost 3.5 times the risk to die over a 10-year follow-up period. Now, let's do another think, pair, share. Why do you think these folks are also more likely to do worse if they have depression? What do you think are risk factors? You could shout it out. Lost independence, absolutely. Lack of support. Inability to exercise, hopelessness, right?
Loss of social connections.
Absolutely, loss of social connections. Say you can't walk anymore, then you might not be able to go mall walking or go to Bridge Club or go to those places that you normally would to connect with peers. Absolutely, right. What about folks who have aphasia or can't express themselves anymore, right? You could just imagine the impact that that must have. So we're right on target. So the degree of disability, their presence of pre-stroke depression, the level of cognitive impairment or inability to express themselves, and certainly anxiety. Those are all risk factors for doing worse post-stroke with depression. So just like coronary heart disease, there's strong evidence for really being aggressive with treatment post-stroke. So antidepressants are modestly beneficial, and this is based on a 2008, so a little older Cochrane review. But we also know that care management, so getting some support with RN case managers around these folks' care, because this is complex levels of care. We'll talk a little bit more about this collaborative care model in a moment. Okay, so really important to treat, because interestingly, there's a really neat study that showed that if we treat to remission in people with stroke, they do much better, and it's regardless of the degree of disability related to their stroke. So it's really important, regardless of where they are in their degree of disability, whether they have full-sided paralysis or just a minor impact from their stroke, that we really should be aggressive about treating these folks for their depression. Okay. So luckily, in the case of my patient CM, he still had the right-sided deficits, but had really strong family and social support. So it was his family that first noticed the depression creeping in the rehab facility. So they really advocated for treatment, and the rehab physician added on some antidepressant medication, and actually they had availability of counseling in the rehab facility, which was fantastic. And you know what else helped? Adherence, right? Because at the rehab, they give you your medicines, right? So the adherence was perfect. So that really does make a difference. Okay, so our last case for my talk, and then we'll talk more about collaborative care models, but our last case is a longtime patient of mine, CS. She's a 56-year-old female with a history of diabetes, very up and down control, on Lantus, which is a injectable insulin type, et cetera, with hypertension, low back pain, chronic kidney disease stage 3, depression and anxiety. And how many primary care docs do I have in the audience? Just one, a couple, good, right? This is pretty common. These are our patients in primary care. So lots of comorbid illness. And so unfortunately, CS I see monthly because she's a lot of complexity. We try to keep her out of the hospital. So she came in to see me for a primary care visit for her diabetes, and she was profoundly depressed. Her mother and father had died within the same month. This was in the spring of this year. And so she stopped taking a lot of her medications. She stopped checking her blood sugars. I checked her hemoglobin A1C that day, which is a measure of how well you're doing with your blood sugars. It had skyrocketed. Not surprising. She'd really stopped taking her Lantus, her injectable insulin. So unfortunately, with CS, she also developed psychotic features. I noticed that she had a lot of excoriations on her arms. I said, what are these things on your arms? And she said, well, I'm trying to pick the spiders out. And I said, oh, okay. Well, tell me more about that. And she was also, seeing and hearing things. And I luckily had known she had a history of psychotic depression many years ago. But I'm a primary care doc. It's a 12-month wait list to see the psychiatrist in Vermont. So I had to figure out, is this real psychotic depression or is this delirium? So then I did my primary care thing, and I made sure I checked a few labs to make sure it wasn't her renal failure or a metabolic derangement that was causing delirium. And are there residents in the room? Yep. Okay, great. I have a whole talk on delirium, but we're not going to do that today. But so we have to do this. We have to triage. Are we dealing with delirium or psychotic depression? Luckily, all her labs were okay, and I don't think it was delirium. I put her on a little olanzapine, and she did much, much better. Now, I also got support from her therapist with additional treatment, and again, I really was very careful about ruling organic causes of this psychotic break. So she's an interesting case, but I want to talk about this interplay between depression and diabetes. So this is a theme, right? We're seeing every time we add on a chronic illness, we see complications and increase in mortality. It's the same thing with diabetes. So if you take depression and add on diabetes, that you see an increase in mortality and complications from the sugars and also disability from the diabetes. So even for controlling for sociodemographic factors, you see that really dramatic increased risk of death, even in minor depression. So we're seeing the theme with treatment here as well. The treatment algorithms really suggest we should be aggressive about treatment with antidepressants and psychotherapy. And this was a little bit more recent Cochrane review that really solidified that. Now, sugar control is variable in the studies. So I try to do my best to treat the depression because I think it really does impact the adherence to medications. So for CS, with time, her depression improved. And with that depression improvement, her sugar control improved as well. She started taking her Lantus again, and her A1C dropped, not perfectly, but it's down to 8. It's not quite to goal. But I put that little smoothie up there because I also talked about diet with C, and she made some nice adjustments, and we were chatting about different ideas, and the funny thing she said, as I talked about smoothies, she said, Dr. McCray, I am not doing smoothies. No way. So, but she switched out, the white potato for some sweet potato and some nice adjustments there, with a lot of support from her kind of case manager and her personal care assistant as well. So now I want to highlight a little segue here about medication, and especially for the residents and the prescribers in the group. When I put her on olanzapine for the psychotic features, she gained 10 pounds, right? So do you guys see this a lot in your practice? Right. So weight gain, a big factor when we're looking at primary care treatment of psychotic features, or a lot of times folks are getting put on Abilify for adjunctive treatment. I'm seeing a lot of weight gain with Abilify in my primary care practice. So we also had to tackle the weight gain as well after treating her depression. So I'm going to do a quick slide on medication pitfalls that we see in primary care. Hopefully some clinical pearls here for you too. So with atypical antipsychotics, like we just discussed, like olanzapine, we do see that weight gain, and we see hyperlipidemia. So for the primary care physicians in the audience, it's really important to be screening for this and also to be screening for diabetes as we see the weight maybe creeping on for folks who are on an adjunctive antipsychotic medication. Of course, I'm sure you're all familiar with the other classic side effects like tardive dyskinesia or the lip and mouth movements that can be permanent. I had a young patient who had severe depression I was treating in the primary care setting with adjunctive Abilify. She developed some tardive dyskinesia, and we had to stop it and try to find some alternative treatments for her. So NMS, or neuroleptic malignant syndrome, some of you may be familiar with. That's pretty scary when you see it. If anybody has, it's very severe and can be life-threatening with high fevers and muscle rigidity with antipsychotics. And finally, a real key piece, any geriatrician folks here work with geriatric populations? Yes, quite a few. I see a lot of patients with dementia in my practice, and we use antipsychotics a lot at the end of life in dementia in primary care, mostly for behavior, absolutely. So a little risperidol, et cetera, it works wonders. It works wonders. But real key clinical pearl, there's big time evidence that it increases the risk of death. It does, and increases the risk of stroke in our elders. So I, as a primary care physician, I have an informed consent discussion with every family that I might consider prescribing about that increased risk. And I would say 8 times out of 10, they are willing to take that risk benefit because it really can be useful adjunct with behavior disturbance in dementia. So, but just an important thing to think about if you're prescribing as a mental health provider these medications, especially in your older patients. So let's talk a little bit about the SSRIs, which are ubiquitously prescribed, especially in the primary care setting. Now, we know there's a black box warning for suicidality, And so also I have an informed discussion with my patients about that risk, right? And I bring them back within a week to 2 weeks, especially if they're a teen or an adolescent or an early 20-something. Absolutely want to make sure they know to watch out for increased suicidal thinking or behaviors, and that I'm really monitoring that very closely. And then finally, I want to put a little word of caution for using those mood stabilizers like Depakote, et cetera, in women of childbearing age. So I learned this the hard way, okay? So I had a patient who was a 20-something female who was beautifully treated with Depakote for a mood disorder, and it really made her functional. But unfortunately, she got pregnant, and I hadn't thought about getting an IUD in her or offering her some long-term contraception that she might be accepting of. So really important, if you're a prescriber in the room and you have a woman of childbearing age and you're prescribing some of these mood stabilizers, especially the antipsychotics, please consider sending them to their primary care doc for discussion about long-term contraception. Like, we have all kinds of neat stuff now. We have Nexplanons, which are like an implantable device. We have IUDs, many different kinds these days. So there's a lot of options out there so that we can safely treat our patients with more severe mental illness in their most productive, kind of reproductive time of their life. Okay, I'm going with the segues here. Let's talk about pregnancy. So I know pregnancy is not a chronic illness, just saying, okay? At least I'm hoping. So I gave this talk a few weeks ago at UVM for Grand Rounds, and I didn't have the slide in, and afterwards, we do a lot of family medicine obstetrics at UVM. We're kind of old-fashioned GP, we do it all. And one of my colleagues said, you have to talk about depression in pregnancy, because it's really, really important, especially for this interprofessional crowd. You might be taking care of folks who are pregnant and depressed. Well, depression in pregnancy also has a lot of risk associated with it, just like all the chronic medical diseases that we just talked about. So depression in pregnancy increases the risk of preterm birth, increases the risk that you're going to have a C-section. It also increases the risk of SIDS, or sudden infant death syndrome. Excessive crying in the baby, wouldn't that make you more depressed? I mean, who's ever had a crier? I had a colicky baby, it was horrible. And then also behavioral and cognitive problems in the neonate or the child. So think about the impact of that. So if you're depressed in pregnancy, then you have all these challenges with your child. It can be really impactful. So we really need to be weighing the risks and benefits of continuing treatment for depression during pregnancy. Great data for screening, as we talked about, so we should be screening pregnant and postpartum patients. But 9 times out of 10, I'll keep a patient on their antidepressant during the pregnancy. And SSRIs are pretty safe. So there really is, if you look at large reviews, there is really no substantial data that there's any teratogenicity or impact on the fetus during development. So one little caveat for choice of antidepressant is we probably should avoid paroxetine or Paxil during pregnancy. It is the one most associated with this thing called primary pulmonary hypertension of the newborn. It's a mouthful, but we just don't like that to happen for the baby. So I steer more towards the other SSRIs in pregnancy and avoid Paxil. Okay, so I have 5 minutes left. I wanted to briefly discuss integrative behavioral health in primary care and collaborative care models. So collaborative care models are really where we have an integrated approach to treating depression in the primary care setting. It's based on Wagner's chronic care model, and it's really about following evidence-based, guideline-based care, having some decision support for providers, like I mentioned, having the PHQ embedded in your EHR, being able to pull it right up there in the visit. Some method of continuously assessing how you're doing, really those checks and balances, but are you accurately diagnosing depression? Are you following the appropriate treatment algorithm? And usually these models include a nurse case manager to help right? Because in primary care, as somebody mentioned, I think Dr. Fry, we're overwhelmed. We have so many things to contend with in each visit. Sometimes we only have 15 minutes. And as a colleague of mine said, patients with depression can sometimes unpack all of this important stuff, right? And we're also managing that heart disease and the diabetes and the CHF and then that depression. And so for us as primary care physicians, to have some extra support in the primary care setting is really key. It's integral to the success in how we treat depression in primary care. Okay, so the data is incredibly robust for these models of care. And we see increased rates of adherence and better depression outcomes compared to usual care. So in the interest of time, I'm just going to mention that there is a lot of data for all the chronic diseases that we talked about, for heart disease, for diabetes, that these models of care really provide better outcomes. And if you look at, say, the heart disease literature, which is the most robust, you see a decreased risk of cardiac events, just like we saw with the Lexapro studies. So it's not just medication, but it's actually how we're delivering care for these patients with comorbid depression and chronic disease. Okay. So at University of Vermont, we're very lucky to have some progressive things in place. We have co-located counselors and psychiatrists in the primary care setting in some places, not all, but at the academic center. So despite that long wait list to get somebody into the referral center to see a psychiatrist, we're now seeing embedded psychiatric availability in the primary care setting. So the access is improving. This is all brand new. And interestingly, last night we heard a lot from Dr. Clark about what is possible in a nationalized healthcare setting in the UK. Just way, way beyond where we are here in the US. But we're making some progress, I think, state by state. In Vermont, we actually have a waiver from the federal government, from CMS, to actually, we got a big pool of money to take care of all of our Medicare and Medicaid patients in a population health-based model. So we're actually taking on the risk of allocating that money from the federal government towards services. What's really cool about it is that we are using some of the methodology that Dr. Clark kind of alluded to look at how can we improve systems of care for our patients. And so we're really looking at behavioral health as a real strong area of need. And how do we empower these models to happen in the primary care settings, the integrated health model, having a psychiatrist, having counselors in the primary care office, so that our patients who have transportation or financial challenges can get their care right in the medical home. So at UVM, this is coming. We're also getting nurse care managers that are slowly infiltrating into our practices as part of this federal waiver. So even despite the challenging politics of our time, there is some progressive health policy happening in the US, and I think it's a really important area for us to move towards in the treatment of depression and mental illness in primary care. So we're going to wrap up with our last interactive exercise, because I have 1 more minute left, and I want you to think about this notion of integrated behavioral health and collaborative care. Are you doing it? Are you not? What do you see as some of the barriers? Are you excited about it? Think about it, share with your person next to you, and then we'll finish up in 1 minute. Okay, great. I'm going to have you finish up your lively conversations. This is great. And bring your attention back to the room. Excellent. So anyone want to share some of their thoughts about integrated behavioral health models or collaborative care? What were the themes percolating? Just shout it out. Good, bad, not happening, happening?
Well, we all know that it works.
Okay.
It's difficult to,
Right. Yes. Absolutely. Yeah. Good. Great. So putting it into action. A lot of barriers there, financial, et cetera. Other thoughts? Yeah. Yes?
At the meeting we use it, but we also have something really nice called telehealth, where we do like consults, neurology or endocrinology, and they can either give us a response to a question regarding a particular issue,
Right.
or they can develop a behavior of children.
Absolutely. So thank you for bringing that up. I'm out of time, but I have a few slides on what if you can't afford it, or what other models are there out there. Telehealth, lots of data for it. And certainly we heard about the programs happening in the UK, including the internet-based programs, a lot of data emerging. But how do we make that accessible for our patients, not only in the VA setting, but in all primary care settings? Yes. And did you have a... Yes. Absolutely, yes. And interestingly, there was one study that showed it actually did better than we do in primary care. So there's something about it that really, I think it's where we might be heading. Think about the reduction in cost and the improved access for our patients, including in rural settings like in Vermont, et cetera. So I think there's incredible promise there with the use of kind of emerging online and asynchronous methods of care, telehealth, et cetera. So with that, thank you so much for your attention. Appreciate it.